No, sir, you can start.
Sure. Good evening, ladies and gentlemen. Welcome to Secrets of Neurology, clinical pearls coupled with recent therapeutic advances. Today is episode 3rd, and we have Trembler's Tale. Our course director, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan, have brought in today a galaxy of stars to enable us to get enriched. We would like to close this by 9:30 tonight. An honor and privilege to introduce to you our program director, respected Dr. Sudhir Shah, professor and head of department, NHL MMC and SVP IMSR Ahmedabad. Dr. Sudhir Shah is also director of neurosciences at prestigious Sterling Hospital, Ahmedabad. Many awards and accolades to his credit. Just to mention a few, because of his pioneering work, support to patients and community, Dr. Sudhir Shah has also been conferred with prestigious Padam Shri by Government of India. He is also recipient of Dr. B.C. Roy Award. He is also recipient of UNO Award. Our second preliminary is Dr. Lakshmikant Narasimhan. Dr. Narasimhan is Director and Professor, Institute of Neurology at prestigious Madras Medical College. You can see here, he is also having a lot of accolades, rewards to his credit. He is recipient of Literacy Advisor from ARN. He is recipient of prestigious A.B. Baker Award as Global Best Teacher. It is an honor and privilege to have both these two dignitaries as program director. May I request you to enlighten us, sir?
Thank you, Dr. Manoj, for those kind words. Well, I'm here to welcome all of you, all the delegates and speakers for the 3rd episode of the unique, wonderful webinar series scheduled on last Friday of every month, that is 8 p.m. onwards. And we are extremely lucky that previous 2 programs had a terrific success. This program is very meticulously and carefully designed by my friend Dr. Lakshmi Narasimhan and myself with a view to conserve and promote clinical neurosciences, at the same time to enhance our clinical knowledge in the recent advances of therapeutics, etc. I'm sure this is going to be useful for one and all, although this is primarily meant for the postgraduate residents and of course the fresh junior practicing neurologists. This program has structurally, it is a case discussion followed by case dissection. There is anatomical localization. There is a lot of electrophysiology, a lot of neuroimaging discussion, arriving at the anatomical localization, then differential diagnosis, and then having read to the diagnosis, there will be discussion on the recent advances of that particular case. And fortunately, we have one of the brightest star of Indian neurology from East, Dr. Rishikesh Kumar, as the luminary or the expert neurologist to guide our discussion on the case, as invited by Professor Matthew. जैसे कौन बनेगा करोड़पति में एक्सपर्ट होता है, ऐसे we have expert today, Rishikesh Kumar. Who does not know Rishikesh? He is my personal friend, but basically he is a head department of neurology in charge, Parkinson's disease movement disorder program director, RDCM Research Center, vice chairman Institute of Neurosciences, Calcutta. His contribution to Movement Disorder Society of India is immense. He has been coordinator to several things and several conferences, but basically his fellowship is in Parkinson's disease and movement disorder subspecialty of neurology, which he did at Ontario, London in Canada. He had several papers and publications and a lot of other accolades, which I don't think I have time to discuss. May I have the next slide, please? with this, we have two students who are going to discuss primarily the case. One is Dr. Padma. So basically today the institute is Christian Medical College, Vellore. You know, Vellore CMC is one of the most premier institute of India, and also it has a very old and classic department of neurology of India. One of the oldest, I would say, after Madras Medical College, etc. So the resident doctor who is going to start the case is Dr. Padma JP. She is a resident in the same department. Then another resident is Dr. Rajni Kumar Ponana. He will be discussing the case little further. Next slide, please. Dr. Aditya Nair is an assistant professor from the same institute. Next slide, please. He and Dr. A.T. Prabhakar, CMC, is a professor, Department of Neurology, CMC. They will be discussing the anatomical aspects, electrophysiology, and imaging, etc. Next slide, please. Dr. Ajit Sivadathan will add to the basic understanding of the case. Ajit is interested in clinical neurology, neuromuscular disorders, neuroimmunology, autonomic nervous system. I think, as the name of the case suggests, somewhere here the clue. Next slide, please. And of course, we have none less than Dr. Vivek Mathew, a young, relatively man from Maharashtra who is now settled at Vellore. Is an HOD and professor of neurology, CMC Vellore. His areas of interest are clinical neurology, clinical neurophysiology, epilepsy, etc. I think without wasting much of the time, I would straightway request the team to start the proceedings. I must once again confess that although me and Lakshmi both are course directors, if I have to give real credit, I think Dr. Lakshmi deserves a real applause. It is real hard work, and this is how the whole webinar series is in front of you. And we hope to continue for another coming months, hopefully several months, depending upon the response of the delegates. Thank you very much. Enjoy the sessions. Dr. Mathew, please take over.
Thank you, sir. So we'll start with Dr. Padma, who will present the case.
Can you share the screen, sir?
Yes, ma'am.
Good evening to all. Today I am going to start with a case discussion, a tremulous tale on behalf of Department of Neurology Science, CMC Vellore. This is a 47-year-old gentleman from Patna. He is working in a shop as manager, presented with tremulousness of the limbs for 6 years, with recent worsening for past 9 months. He was apparently normal 6 years back. He was working in a shop as manager. In 2014, he noticed insidious onset tremulousness of right hand while writing. He used to support the right hand with left hand. He also felt the tremulousness while counting currency as well. There was mild shaking of both hands while holding the glass, which was more predominant on the right side than the left. But he was able to drink without spillage. He was able to carry out all his routine activities with mild difficulty. There's no abnormal posturing of hand or neck noticed at that point of time. There was no tremulousness of other body parts. His shaking movement was not seen at rest and sleep. These symptoms were mildly progressive till December 2019. From December 2019, he noticed increased tremulousness of both hands. However, he was able to carry out his routine activities. Gradually he noticed tremulousness of both legs while getting up from the chair. This tremulousness persisted even while walking. The severity gradually increased over the next few weeks to an extent that he had difficulty in wearing his pants in standing position. He also noticed the same difficulty while lifting the leg for putting his pants in his sitting position. However, he was able to manage by himself at that point of time. He noticed increased tremulousness of both hands from February 2020, so that he found difficulty in drinking a glass of water. There was spillage of water when he is taken to the mouth. He felt difficulty in holding a pen or a plate of food with right hand. His wife noticed that there was mild tremulousness of head while sitting and walking, which was not present in sleep or lying down posture. The tremulousness of the hands and the legs were gradually increased over few months, and from June 2020, he noticed tingling paresthesia of both feet and hands. However, he was able to perceive hot and cold sensations, and there was no history of burns or ulcers. There is no history of hot and cold sensations or wash basin phenomenon at that point of time. At present, he is not going for his work, and he is dependent on all activities of daily living. He needs support for taking food, drinking water, and brushing his teeth because of the tremulousness. However, he is able to walk without any support with tremulousness of body as well as legs. There is no history of reduced vision, double vision, or oscillopsia. There is no history of any difficulty in chewing or facial deviation or hearing impairment or speech difficulty. There is no history of any bowel, bladder symptom or erectile dysfunction. There is no history of any sensitivity to stimulus for this abnormal movement. There is no history of slowness of activity or slowness of speech, no imbalance while walking or weakness of limbs, no history of aggravation or relieving of symptoms with alcohol. There was no history of any chronic drug intake which can be attributable to the tremulousness. There is no history of any trauma or encephalopathy prior to the illness or during the course of the illness. He consumes alcohol in dependence pattern for the past 17 years. He takes mixed diet. There was no history to suggest clumsiness of gait or imbalance or tremulousness in childhood. And he used to participate in sports in school days also. There is no history of similar illness in the family, the form tremor or Parkinsonism or cognitive impairment. He received treatment with propranolol, clonazepam, primidone before coming to CMC, but there was no significant benefit with the medications. This was his pedigree, there was no significant family history. Summarizing the history, 47-year-old gentleman with asymmetrical onset tremulousness of the hand for the past 6 years, which was predominant in action, with recent worsening and progression to involve other body parts for the past 9 months, with a history of mild sensory symptoms. So now we are going to the examination to characterize the type of abnormal movement. I'm handing over the session to Raj. Halivam, can you play the video?
Yes, I'll do that.
Good evening to all.
So I'd like to describe the examination, and informed consent has been taken.
Just a minute, okay.
Yes.
Yeah. Okay, is it visible?
Yeah. So here we can see the first video. Initially, he's at rest. Can you please pause it for me? The first starting. Yeah, just 1 minute. At rest, he can see him at rest, sitting with both hands on thighs, with gravity eliminated, and there is no movement in upper limb. Can you start now? Yeah. Then after that, on assuming a posture, there is an asymmetric rhythmic oscillatory movement of the wrist and shoulder on the right side, more on right side than left side, with amplitude more on the right side, and he also had mild head tremor. On assuming the wing beating posture, we notice marked increase in the tremor amplitude, right rather than left, and the tremor appears to be overflowing to the lower limbs as well. The right side, examining the head at rest at neutral position, he had a no-no type of head nodding tremor, and the tremor disappears with neck movements. On finger testing, we notice an increase in amplitude of tremor in the upper limbs, right more than left. As finger approaches to the target, there is an increase in the terminal amplitude, so that intentional component is suggestible, and there is no over shooting of the target. There is no appreciable dysmetria. On the right side, here we can see that patient is grossly disabled by the severity of the tremor, as evidenced by the fact that he is unable to transfer water between glasses. On eye movement examination, here the pursuits are being tested and are found broken. Coming to the examination of saccades, horizontal saccades were hypometric in nature. On gait examination, there is a high step-phase gait predominantly on the right side with waddle, and he had a wide-based stance as well. Patient is able to do heel and toe walking with tremulousness of the legs, and he is also able to get up from sitting and squatting position with significant tremulousness. On Romberg's, he doesn't have any exaggerated sway, and it's negative. Except in the tremor. Yeah. Can you please take out the video, ma'am? I'm sharing the screen. So coming, So coming to the other relevant neurological examination, his vitals were normal, no orthostatic hypotension, and on general examination is normal, no stigmata of chronic liver disease, no neurocutaneous markers, no peripheral nerve thickening, no pescavus or kyphoscoliosis, no markers of nutritional deficiency or heavy metal poisoning seen. Other systems were normal. CNS examination proper, cognitive examinations normal. Coming to cranial nerves, no abnormality detected, fundus was normal, and in the motor system, additional component was he was areflexic. Coming to the sensory system, vibration in JPS was decreased till ankles and Romberg's negative. And there are cerebellar signs in the form of intentional tremor. So I would like to explain the movement disorder as an asymmetric, predominant postural and kinetic high amplitude tremor involving distal and proximal upper limbs, lower limbs, and the head without voice tremors. So finalizing the summary of the history and examination, he is a 47-year-old man presented with insidious onset mild non-disabling tremors involving predominantly right upper limb for 6 years with recent worsening and progression since last December 2019. In recent, now on history, there is a history of sensory symptoms since 6 months with examination revealing sensory neuropathy and slow saccades. So, and I would also like to further quantify the severity of the tremor as follows. So 4 ratings have been given for all the tremors, and significantly he is having grade 3 in postural and kinetic tremor, and grade 0 in rest tremor. It's not seen clinically, and grade 2. It's an intention component which is definite in the intention tremor. So I would like to characterize this tremor syndrome in the form of it's a subacute worsening of 6 years. 6 years with subacute worsening, tremor which is action, postural, and intention, with the cerebellar component in the form of hypometric saccades and intention component with peripheral neuropathy. So with this constellation of symptoms, I would rather go in an algorithmic approach with 2 ways: combined tremor syndromes or isolated tremor syndrome. So first we will go through the combined tremor syndromes. Combined tremor syndromes, you have the other feature of Holmes tremor, which is a proximal predominant high amplitude tremor, and it is mostly seen in symptomatic brainstem and cerebellar lesion in view of asymmetry and recent worsening. So Holmes component has been also taken into consideration, and a neuropathic tremor. So for this combined tremor syndrome etiology, I'm taking into consideration as inherited, acquired, or recent acquired on an inherited overlay. So coming to an acquired, I would like to consider autoimmune initially with anti-GAD or anti-TTG or white matter disorders, which can cause symptomatic lesions affecting the CNS as well as the PNS. But in view of the long period of duration of illness, 6 years, it seems to be unlikely. But the recent worsening of since 6 months, 6 to 9 months, can explain a possibility of autoimmune etiology which could be treatable. However, there is a long duration, absence of any GI symptoms related to celiac are unlikely, makes it unlikely. Coming to the second possibility, I would like to keep as alcohol, drug-related toxin, toxin related. In alcohol, neuropathy, cerebellar ataxia, and tremor is fairly possible. But the odd points being, it doesn't have any significant gait ataxia for 17 years of being alcoholic, and no significant positive sensory symptoms. And generally, in a drug-related or toxin-related tremors, there will be generally symmetrical and more distal. But here we have seen the asymmetry is the main component since from the beginning, and it's the proximal component as well. So we can explain the recent onset proximal component with a symptomatic lesion in the brainstem and cerebellar, and that could be explained with the possible encephalopathy. It can suggest Wernicke's or ODS, but such type of history was not obtained in any of the point in history. So this is likely unlikely. Then coming to the nutritional, in a chronic alcoholic, niacin deficiency and vitamin deficiency, niacin deficiency has been shown to cause such type of trauma with neuropathy and mild ataxia. But the other findings, the main findings of dermatitis and cognitive decline were absent. And vitamin C, vitamin E is also seen to present with ataxia, neuropathy, and trauma syndrome. But there is no history of malabsorption or any weight loss in the history. Coming to the next, inherited causes. In India, the long period of 6 years when taken into consideration with the symptoms of cerebellar and neuropathy, we can take into consideration the spinocerebellar ataxias in the first instance. But here the odd points being, there is no autosomal dominant family history, and there is no significant cerebellar signs apart from the saccades and absence of pyramidal involvement. However, the phenotypical presentation could be varied, and I would like to consider CA2, which is predominant hypometric saccades related, and 3 and 12, which is predominant tremor related ataxias, inherited ataxias. So coming to the next metabolic, I would like to consider Wilson's. As in India, before young fellow like 40, 47 years, I would like to consider Wilson's as a differential because it is a treatable condition. However, in spite of the CNS manifestations, what we are seeing, there is no KF ring, and there are no extrapyramidal features till now like bradykinesia, rigidity, dystonia, history or an examination, or no pyramidal signs like spasticity or pseudobulbar effect. And the presence of significant neuropathy could be a little unlikely in Wilson's. Then considering in view of the multisystemic involvement like CNS and PNS, I would like to consider mitochondrial cytopathy as well, and which could include Golgi mutation, SANDO, sensotoxic neuropathy, dysarthria and ophthalmoparesis, and neuropathy, ataxia, retinitis pigmentosa as well. But the fundus examination was normal. So the other possibilities I would like to consider were the Fragile X tremor ataxia syndrome. In view of this syndromic presentation, combined tremor syndrome, but the odd points here being the no family history of mental retardation, no history suggestive of any ovarian failure, and no autonomic dysfunction or mild cognitive decline, and age is not age of onset is not supportive, as the FXTAS is mostly seen in 6th or 7th decade. Coming to Refsum's, I would like to consider Refsum's as the same presentation. The main symptoms are ataxia, neuropathy, along with tremor. But here there are no childhood onset of symptoms, no history suggestive of any clumsiness or any milestone delay in childhood. And there are no, on examination, there are no nerve thickening and no anosmia, retinitis pigmentosa, which are the clinical hallmarks of the Refsum's. And finally, we can consider leukodystrophies, which can, with peripheral neuropathy, which can affect with strategical midbrain or the cerebellar with brainstem localization, which could explain the cerebellar with proximal Holmes tremor, that Holmes tremor. But however, here the absence of pyramidal signs and optic atrophy I would like to keep this as a last differential. Then, apart from this combined tremor syndrome, I would like to consider finally as an isolated tremor syndrome as essential plus syndrome if after investigation it's a diagnosis of exclusion. So I would like to consider these possibilities and I like to evaluate with investigations.
We will go to Dr. Aditya, who will present the electrophysiology. Dr. Aditya is an assistant professor of neurology with us, and he has an interest in clinical neurophysiology. And he was the one who worked on this patient's electrophysiology to try and characterize the phenomenon that we were seeing.
Raj, can you stop sharing electrophysiology?
Sure, sir. Thank you.
Good evening to all. Thank you, sir, for the kind words. I'll be talking about an electrophysiological approach to this patient who had presented to us with a tremor dominant syndrome. So, as the presentation was tremor, we had started our evaluation with a polymyographic examination. In this gentleman, we had used a 6-channel study where 2 channels were for EMG and one was for accelerometer. And tremor analysis was done in 4 states, with each stage being for 30 seconds. These states were rest, poster with 1 kilogram loading, and for entrainment. The reason for these various steps will be explained in both hands. So in rest, we find that, so this is the accelerometric recording that we are seeing from upper limb. What we are able to see is that there is significant amount of EMG muscle artifacts on the right side, that is on the right upper limb. This is, and while there is actually no movement which we are able to see on the left side. So even though clinically there was no rest tremor, we were able to get some surface EMG recording from this side. And this second diagram is the surface EMG muscle burst pattern. So what we are able to see, the ones in blue are the extensors, this is the extensor carpi radialis, and the one in red is the flexor carpi radialis. What we are able to see is that there is an arrhythmic burst that is present, and the time duration is 500 milliseconds. So from 13 to 14 is 1 second, and we are seeing that the frequency is around 3. And at rest, there is a co-contraction that is occurring between the flexor and the extensor muscles. We further like to classify, we also looked at the, whether it's possible to look at the burst duration, and we were able to calculate from the onset to the end that the burst duration came to be around 150 milliseconds. Subsequently, we did a frequency transformation, and we looked at what was the tremor frequency. So here, this is the accelerometric frequency peaks. This is the EMG extensor frequency peaks, and this is the flexor frequency peaks. What we are likely to look at is the movement that is occurring in the accelerometer correlating with the muscle burst. And we noticed that around 3 Hz, so this is from 0 to 5, this comes to around 3 Hz, there is a movement which is occurring, which is peaking at the same time with the muscle. And so this tremor is contributing to the movement at the accelerometer, while the others could be mechanical tremor movements. Subsequently, we looked at in poster. Again, in poster, we see that there is a marked increase in amplitude as compared to rest, and here we are seeing that there is left-sided and right-sided involvement from the accelerometer. Here, in muscle, when we are looking at individual muscle bursts, we find that actually they are asynchronous in contraction. That is, the extensors, the flexors are not co-contracting; they are asynchronously contracting. And when we look at the frequency pattern, what we are able to see very clearly is that there is mostly a single frequency that is beating for in the accelerometer, in the extensor muscles, in the flexor muscles, and all are around 3.6 Hz. So this is the frequency and this is the amplitude. And what we interested is primarily the frequency. So this is a low amplitude tremor in poster. We then loaded the limbs in poster with a 1 kilogram weight. And we noticed that these tremor frequencies are continuing in the right and the left side. And significant amount of acyclic contraction continues to be seen in the EMG muscle burst. And when we look at the frequency pattern, what we are able to clearly see is that the frequency is maintained at 3.6 Hz, and it continues to be maintained between the extensors and the flexors. So loading here has helped us in understanding that this frequency is being maintained in spite of loading, and this is a central oscillator, and this is not because of mechanical components that might be contributing to the tremor. We also tried to entrain him to look at if there was a functional component to the tremor. So what we have done here is we have entrained the left hand at varying frequencies. That we ask him to move his left hand at different speeds. So the frequency peaks are different, while the right upper limb frequency did not change at all, indicating that there was no significant distractibility to the tremor. Similarly, he also did ballistic movements, where a quick movement on the left side failed to produce any change in the tremor on the right hand, indicating there was no significant functional component to the tremor. We also looked at if there is a difference, because the tremor involved the proximal, intermediate, and distal muscles, if there was a difference in the tremor frequency between the proximal and distal sides in one limb. So this is an EMG diagram from the right upper limb, where we have kept surface EMG leads on the APB, the FCR, and the biceps. Each time second is 200 milliseconds, so 5 of that will come to 1 second. So here we have a 3 Hz frequency tremor, and it is the same in all the muscle groups, indicating no significant change in the frequency. So what we have understood at the end is that there is a slightly arrhythmic, predominantly 3.6 Hz tremor with the EMG burst of around 150 milliseconds. On assuming posture, the frequency is maintained and the loading did not significantly change the tremor frequency. So how this has helped us is it has given us a frequency. It has helped us in ruling out other possibilities like peripheral myoclonus and cortical myoclonus, which sometimes may mimic tremors based on the burst duration, where both of them have a burst duration of less than 50 milliseconds. Here, burst duration of a higher duration has helped us in ruling out those differentials. Entrainment and ballistic movements have helped us in ruling out functional components of the tremor. And in spite of loading, the tremor frequency holding on indicates that the central driving force of tremor is a central oscillator and not a peripheral problem. Because the patient had significant neuropathic involvement, we subsequently went ahead with a nerve conduction study. As can be clearly seen, the lower limbs motor nerves were unexcitable, while in the upper limbs, there was significant prolongation of the distal latency in the median nerve with significantly slow conduction velocity. We subsequently looked at the waveforms, and we found that this was such a demyelinating neuropathy, and there was no significant change among the proximal and distal simulations of the waveforms. There was no features of a conduction block or a temporal dispersion. So these were features which were suggestive of an inherited etiology. We also looked at other blink reflexes and facial motor conductions, and all of them revealed increased prolongation, confirming the demyelinating nature. To look at where was the conduction velocity slowing, was it distal or intermediate, we utilized the terminal latency index, which was calculated by the below equation. And we found that the numbers came around 0.29 and 0.4 for right and left median nerves. And all this suggested an intermediate or proximal segment slowing. So considering a relative positive symptoms for this amount of slowing in a nerve conduction study, we considered an inherited neuropathy. The younger brother who had accompanied the patient at that time was examined, and he did not have any significant chest fever, and his nerve conduction studies were normal. We subsequently went ahead with a neuromuscular ultrasound to look at whether what was the type of nerve thickening enlargement that we would see for a demyelinating disease. So we found that there was a significant more than 2 standard deviation enlargement of the proximal roots and the arm segments of the median nerve up to the C5 root, and distal tapering in the below elbow segment. And this enlargement was homogeneous and diffuse. I'd like to underscore this point, as there was no multifocal thickening or change in the diameter. It was a homogeneous and diffuse enlargement in the proximal segments. We also did autonomic function test, and it was clearly found to be normal. Both the cardiovagal and the adrenergic functions were normal. So the NCS has given us an additional information that it was a demyelinating neuropathy, and we also get information with the absence of conduction blocks, uniform slowing, and absence of temporal dispersion that this is suggestive of an inherited pattern, which is also confirmed with the nerve ultrasound. So considering significant nerve conduction study involvement showing neuropathy and such a tremor, we postulated the possibility of a neuropathic tremor. I'd like to end my slides giving points for and against tremor or being of neuropathic origin. point for tremor being a neuropathic origin was that the tremor activation is primarily in postural and kinetic. The tremor frequency is being supported. We have literature to support that you can have neuropathic tremors at this frequency. And primarily, this has been reported in time demyelinating neuropathies in literature, as was in our case. But there were significant points against this localization. One was a significant asymmetry which has been there from the beginning and has persisted all throughout the 6 years, even during the worsening. The amplitude of the tremors appear to be unusually high and there was significant proximal predominance. And there was no significant change among the tremor frequencies between the distal and proximal muscles. And we could not explain the ophthalmological findings if we were to localize the entire disease from the nerve. And so there were significant points against the tremor being of neuropathic origin. I'd like to end my slides with these.
Thank you, Aditya. So as you can see where we are going, so we had a debate by this time in our department as to whether this patient has a primary tremor disorder or does he have a neuropathy which is driving the tremor. So we could not reach a consensus on this, and therefore we had some more functional neuroimaging to go ahead, which Dr. Prabhakar will be presenting. At this point, if Dr. Rishikesh is here, could I request any comments from Dr. Rishikesh on this?
Before functional, we should discuss this case, at least clinically, for the residents. This is a wonderful, very, very difficult case and very interesting, I would say. First of all, what we can see that tremor is a dominant symptom. Tremor is a dominant symptom. Let's start from the basics. When we present a movement disorder case, we don't jump to tremor. First of all, you present that what is the type of movement the patient has, and then we give this looks like tremor. For example, for this patient, as we know that tremor, the key words are rhythmic involuntary oscillations. So rhythmic is a very important word. So when we present this case, the first slide should be, yes, the patient has a rhythmic movement, which is distal as well as proximal, as we see in this patient, proximal more than distal, which was there on the rest, posture, as well as kinesis, action also, and looks like tremor. And at the same time, you can add very clearly that there is no jerky component, so you remove myoclonus. There is no posturing, so you remove dystonia. So to the listener, you have made it very clear that you are dealing with tremor, not myoclonus, not dystonia, because first step is that. If we made the wrong choice, then whole practice is futile. So you did the right thing. This is tremor, no doubt about that. But I'm just telling for the students, not for the senior people, right? So this is a tremor which was rest action as well, rest kinetic as well as intentional. One more thing. I take the point that patient has all three components. I could see very clearly the patient has bad postural component, postural tremor. I could see very clearly that patient has kinetic component, right? One thing, when we say the rest tremor, which the patient has, I agree with that. But when you see the patient has rest tremor, we could not demonstrate properly on the video that the patient has rest tremor. Because when we say the rest tremor, patient should have whole forearm resting and the hand hanging around so that you can see the rest, right? In this patient, when you see the patient whole arm was on the lap, whole arm, including the hand. So any tremor, you are stopping